or all right.
Yeah.
Now,
Welcome to everybody for this faculty lecture. Nishant is going to talk to us about approach to laparoscopic inguinal hernia repair, which is, I think, a very important topic considering that it is done by most general and laparoscopic surgeons. Over to you, Nishant.
thank you so much, sir. A very good evening, everyone. So, like sir said, it's a very common procedure. So, I'm hoping it should be a pretty straightforward class. We will talk a little bit about the laparoscopic anatomy and the 2 or 3 types of inguinal laparoscopic inguinal hernia repair approaches, and should be a pretty straightforward class. Now, before we start off, first we need to know what is an inguinal canal. So, first years, okay. Before I go to that, I'll just give you a quick way of trying to understand what the inguinal canal is. Inguinal canal is nothing but a tunnel. Now, I'm sure all of you would have seen how a tunnel looks like. You'll have an entry, you'll have an exit, and you'll have walls on either side. You're going to have a roof and you're going to have a floor. All right. So inguinal canal is nothing but a tunnel. So you're going to have an entry, which is through which the cord structures are going to enter. And then you're going to have an exit through which the cord structures are going to go out and go into the scrotum. So the entry is in the fascia transversalis and the exit is in the external oblique aponeurosis. Now, like I said, you're going to have walls on the either side. So that kind of correlates to the anterior wall and the posterior wall. The anterior wall is formed by the external oblique muscle and the external oblique aponeurosis. And you can see that the anterior wall only kind of comes forward, curls and forms the floor also. So it's going to come like a J shape, not only the anterior wall, it also forms the floor. Now the floor is nothing but your inguinal ligament. And similarly, the posterior wall and the roof are basically a single common entity. So the posterior wall, you're going to have your internal oblique and the transversus abdominis muscle. And as it goes up, you're going to get, when they both combine, we're going to call it as a conjoint tendon. So the anterior wall and the floor are the same. The posterior wall and the roof are the same. And this is basically your inguinal canal. Now, quickly, first years, Sai Likit. Can you tell me what is a direct and an indirect inguinal hernia?
Hello, sir.
Yeah, go ahead, Sai Likit.
Direct inguinal hernia.
Don't waste your time, man, because there is a lot to cover.
I think he must be having some connectivity issues. Suprit? Okay, if not Suprit.
Hello, sir. Hello, sir.
Yeah, go ahead, Suprit.
Sir. So direct inguinal hernia is that the hernial content is from the posterior wall directly it is coming out, sir. Indirect means it will from deep ring and through deep ring and inguinal canal superficial ring it will come. That is it.
So something that comes out through the inguinal canal, through and through, is what we call as the indirect inguinal hernia. And something that comes out from the posterior wall, like you said, and that is bound or kind of defined by what we call as a Hasselbalch's triangle. So the Hasselbalch's triangle is bounded by the inferior epigastric vessels laterally, the lateral border of the rectus muscle medially, and floor is by the inguinal ligament. So this is the Hasselbalch's triangle, and anything that comes out from here is what we're going to call as the direct inguinal hernia. So in short, the easiest way of differentiating a direct and an indirect inguinal hernia in the OT or on table is by identifying this particular structure, that is the inferior epigastric vessels. So anything medial to it is the direct hernia, and anything lateral to it is the indirect hernia. Now, before we get into the laparoscopic anatomy of the inguinal region, first thing that you need to know are few landmarks which you're going to see as soon as you're going to enter the abdomen. So there are three cord-like structures that you need to know. One is in the midline. Okay, this is in the midline. This is called as the median umbilical ligament. Then there are two fatty structures on either side. That is called as the medial umbilical ligament. The mid one is called as the median. And then you're going to have a blood vessel running across, and that is called as the lateral umbilical ligament. So this image is not very clear, but I chose this because you could see the median umbilical ligament and the medial umbilical ligament quite prominently. Now the same thing has been shown in this particular image. You can see the one in the midline is called as the median. All right. On either side, you're going to have fatty structures that is called as the medial, and the two blood vessels or the vascular structures you're going to see are called as the lateral umbilical ligament. Samir, can you tell me what each of these are? What is the median? What is the medial, and what are the lateral umbilical ligaments? What are the constituents, or what exactly they are? Okay, if not Samir, then Ainas.
So the median umbilical ligament is like the remnant urachus, sir.
Okay, obliterated urachus. That is the word you're supposed to use. Next.
So then, like the medial umbilical ligament will be the obliterated umbilical artery, sir.
Okay.
And the lateral most will have the epigastric vessel, sir.
Correct. And the lateral umbilical ligament are your inferior epigastric vessels. So now I told you to remember one particular point. How are you going to differentiate between the what is that? Direct and indirect inguinal hernia? What is the one vessel you're going to look for?
Inferior epigastric.
Inferior epigastric.
Inferior epigastric. So anything which is medial to the inferior epigastric artery, we are going to call it as the direct inguinal hernia, correct? So any hernia that you're going to see between the lateral and the medial umbilical ligament, you're going to call it as the direct inguinal hernia. So these are just more tricky ways of asking you the same question. All you need to remember is the inferior epigastric vessel. Anything medial to it is the direct, anything lateral to it is the indirect. Now, quickly, can someone tell me what is triangle of doom, triangle of pain? Nikita.
So the triangle of doom is where the vessels are there, sir.
Which vessels?
External iliac artery and vein, sir.
Correct. Not gonadal, it's the external iliac.
external iliac.
Next. And triangle of pain?
Femoral branch of genital femoral nerve, lateral cutaneous nerve.
Done. So those are the nerves. So do you know the boundaries by heart?
Yes, sir. Triangle of doom is medially by vas deferens, laterally by testicular vessels, floor by peritoneal folds. Sir.
Okay.
Triangle of pain, medially by testicular vessels, peritoneal fold inferiorly, laterally by iliopubic tract.
Excellent answer. Now, for those of you who are confused, let us go step by step. I want who are the first years?
Likit and Suprit, sir.
Okay, who was the one who has a good connection?
I have a good connection, sir.
Okay, good. Suprit, now I will get you to answer everything. All right. So this triangular structure is the external inguinal ring or the superficial inguinal ring, and the deep ring is a oval shaped structure, correct? So now let us assume we are looking at the inguinal region from the inside. Now, what are the contents of the cord structures? Three main contents. What are they?
What? I didn't get that.
What are the contents of cord structures? Something goes inside the inguinal canal, right? So what are the contents of the cord structures?
Come on, man. No, you can't waste
Simple.
time like this.
Okay, will you have?
Spermatic cord.
I know that is called spermatic cord structure. What are
Yeah,
the
cord structure.
contents?
Contents.
Sir, testicular artery.
Okay, so let us bunch all of them and call it as gonadal vessels.
Gonadal.
All right.
Sir.
All the pampiniform plexus veins, everything will bunch them together, call them as gonadal vessels. What else will you have?
Vast difference.
Vast difference. What else will you have?
Genital femoral nerve.
Nerves. Okay, so all these are basically your cord structures. Now, once they're inside the inguinal ligament, they all come together. Yes or no? But outside the inguinal ligament, that means when when they're inside the abdomen, are they a single structure or they are different entities and then merge near the inguinal canal?
They are different entities.
Different entities. Okay. First question. Where does vast difference arise from and what is its function? Okay, what does vast difference do?
Sir, from epididymis.
Correct. And where does it empty?
Sir, it's prostatic ventricle.
Prostate. So prostate is a midline structure or a lateral structure?
It is a midline structure.
Okay. So according to you, the vast difference should go medially. Yes or no?
Yes, sir.
Correct. So it is going to come out of the inguinal region and go in medially. Gonadal vessels arise from which main artery or which main vein?
Sir, inferior.
Huh?
I don't know, sir.
Hey, one main artery, man. Main artery for the entire body. What is that?
Femoral.
Abdominal aorta.
Hey, femoral. Okay, aorta. Okay. Now, if a vessel aorta is in the posterior or anterior aspect?
Posterior aspect.
Posterior. So if any blood vessel has to come from posterior to anterior, it will run straight through the center or it will take a curve and come from the side?
Curve and come to the side.
Come from the side. So your gonadal vessels will come like this, correct?
Yes.
Okay, so vast difference has gone medially. Gonadal vessels have come from this side. Now, same thing, apply the same concept to nerves also. Nerves also arise from where?
Spinal
Cord. Again, do you think the nerves will run right through the abdomen or they'll come from the side?
Outside, they'll come outside.
They'll come from the side like this. Okay, yes. All the way around, they're going to take a curve and come. Now, what is one main blood vessel I asked you to remember, which will help you differentiate direct and indirect?
Inferior epigastric.
Inferior epigastric artery and vein, whatever it is. All right. So anything medial to it, this is called as direct hernia.
Direct hernia.
And whatever is lateral to it, which comes from here, is called as a indirect hernia. Yes or no? Now, what vascular structure does the inferior epigastric vessel arise from? Inferior epigastric arises from which artery or vein?
I don't know.
It is the external iliac. Okay. So you're going to have external iliac vein here. And it arises from it. Right next to it, you will have the external iliac artery also. Okay. So this is the anatomy that you need to know. Now, all of this is basically covered by peritoneum. Yes or no?
Yes, sir.
Okay. Now, if I have to see this area, do I have to cut the peritoneum?
Yes, sir.
So let us say I have cut the peritoneum like this and I have reflected the peritoneum down. Understood? Okay. So once I have done that, my peritoneum fold will be lying on the floor like this. Yes or no? Because I have pulled it down like a curtain.
Sir.
Now look at the structures. Vast difference is here. Gonadal vessels are here. And what is the structure inside and between?
Inferior epigastric.
Okay. External iliac vein.
External iliac vein.
Okay. So if you try to dissect between these two structures, can you damage the external iliac vein?
Sir. Yes.
So what will happen to the patient?
They will hemorrhage and hypernatremia.
Extensive amount of bleeding will happen in this area. That is, and the patient can die. That is why it is called as the triangle of doom. So can you see medially it is a vast difference? Laterally gonadal vessels, inferiorly by the reflected surface of the peritoneum.
Yes.
Okay.
Ah.
Now, inguinal ligament is a structure that you see on the outside or on the inside.
Inside.
Aye. Okay. It's on the outside. Okay. Now, the same impression when you're seeing it on the inside is called as the iliopubic tract. Okay. That is called as the iliopubic tract. It is the impression of the inguinal ligament that you're going to see on the inside. These nerves actually come like this, okay, close to the vessel. So now look at this area now. Iliopubic tract is here, gonadal vessel is here, reflected surface of peritoneum. Now, when you put a mesh, do you use tackers or no?
Sir. Sir. But
Sometimes they use tackers, yes or no?
yes, sir. Yes, sir.
So if you put a tacker in this area, what will happen to the patient?
And if the pain, shooting nerve will get damaged and
Correct. That is why this particular area is called as the triangle of doom.
Pain.
Sorry, triangle of
Pain.
pain.
Yes.
Okay. Now the common area where everyone keeps getting confused is for one triangle, the medial boundary is vas deferens. For the other triangle, the medial boundary is the gonadal vessels. So please don't get confused. Once you have this image in your mind, the anatomy becomes very easy. Okay. So it's all about simple common sense. So medially by the vas deferens, laterally by gonadal vessels, inferiorly by the reflected surface of the peritoneum. You're going to call this as the triangle of doom. Medially by gonadal vessels, laterally or superiorly by the iliopubic tract, inferiorly by the reflected surface of the peritoneum, and that is called as a triangle of pain. Two other areas that you need to know. One is called as the space of Ridgius. This is the retropubic space. This is the space in front of the urinary bladder. All right. So once you pull down the bladder, the area between the pubic symphysis and the bladder is what we're going to call as a space of Ridgius. And anything lateral to it is what we're going to call as the space of Bogros. You just need to know the terms, not very important, but just remember space of Ridgius, space of Bogros. Now, quickly, I will get Praveen.
Yes, sir.
Quickly tell me. There is one. Okay, this is I will give you. This is on the right
Point
side.
out all the triangles and everything here. It's very well displayed.
Yeah. So this is the right side. Okay.
Yes, sir.
There is a defect here and there is some blood vessels here. So that means this has to be medial. That's why I mentioned right side.
Yes,
so
sir.
what defect is this?
Direct tendons.
Direct defect.
inguinal.
Excellent. So what is this structure?
Inferior epigastric arteries.
Inferior epigastric vessels. What is this structure going laterally and what is this structure going medially? What is the lateral one?
Gonadal vessels, sir.
Excellent
Lateral.
answer. And this one?
Vas deferens.
Vas deferens. And can you see there is some fat blood vessel running like this?
Yes,
Can
sir.
you identify that?
External iliac artery. Yes, sir. External iliac artery.
Excellent. External iliac artery. And can you see some white line going across?
Iliopubic tract.
Good. This is the iliopubic tract. All right. So now, so what is this triangle now? You can see I've pulled down the peritoneum. Can you see? This is the peritoneum that I've cut and I've pulled it down. So what is this triangle?
Triangle of dooms.
What is this triangle?
Triangle of pains.
Pain. One extra thing which I will cover. Can you see something running across the bone like this?
Yes, sir.
Do you know what that is?
Corona mortis.
Corona mortis. I will talk to you about it in a while, but just remember that is called as a corona mortis. So this was, I was very lucky. This was one of my patients that I operated, got a very good dissection. So I taken a photo so that it'll become easier to teach you guys. All right. So this is just a quick revision of the same. I don't think we have to run through it. Now coming to the nerves, you can see there are three main nerves that you need to be aware of. One is the lateral cutaneous nerve of the thigh, the genitofemoral nerve, and the third one is the femoral nerve itself. Okay, and everything here you can see is lateral to the gonadal vessel. Now in this image, they have nicely bared the nerve, but keep it in mind during surgery, it is better to leave a cover of fat or fascia on top of it. Otherwise, what will happen once you put a mesh, there will be some amount of fibrosis. So the nerves can get entrapped in the fibrosis. Even though you're not put tacker, the nerves can get entrapped in the fibrosis and can cause inguinodynia. So again, I've put up this image again to show you that I've left this layer of fat intact. I've not dissected the fat to demonstrate the nerves. All right. Now coming to corona mortis. Corona mortis, the literal meaning is, or the translation is crown of death. And it is an abnormal communication between the external iliac vessels and the internal iliac vessels. You can see there is a communication, correct? So this is what we call as corona mortis. Now this communication can either be arterial or it can be venous. Now the trick with this venous part is because it's a vein, when you are operating with 14 millimeters of mercury, when there is a lot of pressure which pushes the vein against the bone, sometimes the vein might become transparent because there is no filling. So you might not at all see the vein. And when you are swiping against the bone, there is a chance you might tear the vein and cause damage and can cause torrential hemorrhage or torrential amount of bleeding. Okay. So remember, unless you are operating in low pressure settings, there is a chance you might miss the venous type of corona mortis. Can someone tell me what is the incidence? Nitya, what is the incidence of identifying corona mortis?
Sir, on 30% of the people can have corona mortis.
It is the other way around. I think the one paper that I read, it said almost 60 to 70%, much higher. Okay, 60 to 70% of the times they will identify corona mortis. And you might think that we are the ones who keep encountering corona mortis, but it's more common in orthopedicians. Okay, in orthopedic surgeries, especially when they're doing hip replacement surgeries, when they can encounter this vessel and can cause torrential amount of bleeding. Now, if at all you encounter this bleeding, first convert to an open surgery and stop the bleeding. The reason is once it tears, there's a chance the vessel will retract, so you might not be able to see it because it will retract behind the bone. So you might have to convert to an open surgery. Or if you have achieved a decent amount of hemostasis, and there is a role of embolization. There is a role of embolization as well. If you are too hesitant to, not if you're hesitant to open, but if the patient is not bleeding badly, you can always place a pack, embolize the vessel, and then go back and remove the pack and do something in the future if you don't want to open. But preferably, as surgeons, convert, stop the bleeding, and be comfortable or have a good night's sleep the day that you have stopped the bleeding. Now, quickly for the first years. Inferior epigastric artery, medial umbilical ligament defect is between these two. What is this hernia, direct or indirect? Okay, Samir, you tell me.
Indirect.
Hey.
Left side. Oh, sorry, medial.
What I've given you, if it's in between the two ligaments, it has to be direct.
Direct.
If it's outside the lateral, then it becomes. So both of these are direct inguinal defects. Now, on the other hand, okay, I'm very sorry. So here you can see the medial umbilical ligament, lateral umbilical ligament, and it is outside. You can see the defect is here. So this becomes a
Indirect.
indirect. Now, Samir, okay, Ainas, if you're there, tell me, what are the indications of laparoscopic inguinal hernia repair?
So like patients who are like if they are any contraindication to open, so like if they're fit for general anesthesia. Sir, like if they have previously undergone any open hernia repair, sir, that is
okay. Ainas, before you get into complicated, simple. If patient has come to you with an inguinal hernia, will you do lap or open?
sir, lap, sir.
Why
Why lap?
lap and what are the indications? That's all my question is. Are there any specific scenarios where laparoscopy is definitely better than open?
Hmm.
Yeah, how many times you have taught you? I don't know why today something has happened to everybody. They are all Nikita. Come on.
Sir,
Okay. Tell me, Nikita. Okay, Parth.
Sir,
Very simple.
recurrent hernia, sir. First,
That is second. I will put recurrent. I will take your answer.
bilateral hernia.
Thank you. Bilateral hernias. Simple, na? If you're doing open hernias, you have to make 2 big cuts. But if you're doing laparoscopy, how many ports?
Three ports, sir.
3 ports. So whether it is unilateral, whether it is bilateral, it is still 3 ports. No extra morbidity. Okay, with regards to the wound size and all. So recovery is faster for the patient. So the absolute indication, bilateral hernias and recurrent hernias, if the first surgery was done open surgery.
Open, sir.
If it was laparoscopy, then you choose open. Okay, at least for your level, remember, if it's laparoscopy, you're going to choose open. If it's open, you're going to choose laparoscopy as the alternative procedure. But that is not written in stone. Okay, for lap recurrence, you can do lap. For open recurrence, you can do open depending upon your expertise. All right. So these are absolute indications. This is what is taught for you, and this is what is expected of you in your exam when you go. In reality, and as per the latest guideline, every patient, you can do a laparoscopic inguinal hernia repair, provided you have the expertise. All right, if you have the expertise and you're sure you're not going to cause any damage, because we looked at all those vessels, right? Triangle of pain, triangle of doom and all. So if your expertise is there, you can do laparoscopic hernia for all the patients. Coming to contraindication.
Sir Ramkrishna sir has joined, sir.
Sir, good evening, sir.
Good evening, Nishant. No, sorry, I joined late. I was a little busy there.
No problem, sir.
Okay.
So coming to contraindications, the only absolute contraindication if the patient is unfit for GA. Why can't we do this under, let us say, spinal anesthesia? Why can't you do an inguinal hernia under spinal anesthesia? Some people do, but I'm saying in general we don't prefer. Why? Who's there? Praveen.
Sir, respiratory sedation we can't give it spinal incisions.
Excellent. Why? Okay, why are you bothered about respiratory and all?
Sir, laparoscopic will be inducing pneumoperitoneum, sir.
Correct. And more than that, in inguinal hernia, what is the position you are operating in? What is the position of the patient?
Head down positions.
Trendelenburg. So that causes
Trendelenburg
more and
position.
more respiratory depression, right?
Yes, sir.
So it does take a huge toll on the respiratory system whenever you're doing a laparoscopic hernia repair, inguinal hernia repair, to be very precise. So patients who have a very bad lung, who cannot tolerate pneumoperitoneum and general anesthesia, should not undergo laparoscopic inguinal hernia repair. So these are the patients where you need to do a open inguinal hernia repair, either under spinal, or if that also is not safe, what is the other anesthesia you can do the surgery under?
Nikita. Nobody is answering today.
LMA we can
Under local anesthesia. Okay, so you can do.
What did you say? LMN?
Sir, I meant mask airway, sir.
No.
Laryngeal mask airway,
Local
LMA.
anesthesia. That is why I knew you were saying something wrong. It's not LMA, it's LA.
Under local anesthesia.
Local anesthesia.
Okay. Now, similarly, there are certain relative contraindications. These two are relative contraindications. If you have a huge inguinoscrotal hernia, sometimes it becomes difficult to operate laparoscopically because the adhesions, because it's an inguinoscrotal, that means it's a long-standing hernia. So you may have adhesions stuck up in the scrotum or to the sac, which you might not be able to reduce it completely laparoscopically. So that time you're forced to do an open surgery. Again, this is not absolute. It's a relative contraindication. Similarly, if patient is on anticoagulants that cannot be stopped for some reason, let us say high risk of cardiac illness or cardiac issues, so you can't stop the anticoagulants. In such patients, because in laparoscopy we are getting into the retroperitoneal space, you might underestimate the blood loss and you might not be able to visualize where all the blood is going. So preferably in such cases, better to avoid laparoscopic hernia repair. Again, I repeat, these are relative contraindications and not absolute. Now, there are two techniques. One is tap, one is TEP.
Nishant, one in indications, patient's choice. If the patient wants, even for the one side, if patient wants a laparoscopic hernia, you do laparoscopic hernia repair. So patient choice is the third indication for laparoscopic repair.
Yes, sir. Point taken, sir. Thank you.
And the other thing is, in emergency surgeries, if the patient is obstructed inguinal hernias, generally you don't tend to prefer to do laparoscopic repair unless you are extremely skilled and you are then you know. But in the exams, you should say emergency surgery, you don't do laparoscopic repair.
Yes, sir. So next, moving on to the types of laparoscopic inguinal hernia repair, there is TAP and TEP. Can someone tell me the difference? I've even put up the image for you. Nikita.
Sir, approach to the space is the difference between the two procedures, sir. How do you enter into the preperitoneal space?
So what is TAP?
One is by TAP is by transabdominal, sir.
Okay.
So we enter into the peritoneal cavity, proper into the abdomen. Then we make a plane to the preperitoneal space by making an incision over the peritoneum.
And TEP is?
Totally extraperitoneal. So we enter into the extraperitoneal plane through the by making a space, just a retrorectus space, and reach the
rectus. Okay, fair enough. You've understood the concept. Now to make it much easier for you guys, for those of you who are not or who haven't seen the two cases, see, unless you have seen it, it becomes very difficult to imagine. I'll try and make it very simple. Assume there is a huge curtain over, let us say, in the stages and all, right? You're seeing these huge curtains on the back wall. The idea is you need to write something on the back wall. So you have to go beyond the curtain and write. Either you can go from one side of the curtain, go in that entire space, write on the back wall and get out. Or you're going to open the curtain, write on the back wall and close the curtain. That is the only difference. So in the first one, where you're going completely hidden behind the curtain, writing and going, that corresponds to your TEP repair. Okay, you can see the entire way there in the preperitoneal space. Whereas in the second scenario, where I said you're going to open the curtain, write it and close the curtain, that is here. You're going through the abdomen, making a cut in the peritoneum, entering the preperitoneal space, doing whatever you have to do, and again closing this area and getting out. Okay. In short, in both the procedures, the mesh is in the same place. The dissection will also remain the same. What you're going to define also remains the same. It's just that the approach to that area is different in these two procedures. All right. So transabdominal is through the abdomen, where you're going to go inside, like how we do a lap chole and then enter the plane. Whereas in preperitoneal, you don't even enter the abdomen. You're completely in the extraperitoneal space. Quickly, few points on how we perform a TAP procedure. First and foremost, we need to empty the bladder prior to surgery. Okay, I will ask Nitya, what are the ways to empty the bladder prior to surgery?
So Foley's catheterization, or we can ask the patient to void before shifting.
Yeah, that is most important. You ask the patient to void. That is the most common. So as PGs, when you're shifting the patient to OT, please make it a point. You ask the patient to void urine and cum. Can you see if the bladder gets distended? It is almost pushing to your medial umbilical ligament. So during surgery, when you're trying to mobilize or define the direct space or where the direct hernia is there, there is a chance you can damage the bladder. So make sure you empty the bladder, ask the patient to void urine. Now, there are certain indications where you have to catheterize. One of it, if there is a large hernia with large defects. Can you tell me why? Is Sanya here?
Yes, sir.
Sanya, why do you have to catheterize the patient if you are dealing with a large inguinal hernia?
The part of it could be found, the wall could be found by the bladder itself.
Correct. So what is such a hernia called as?
Sliding hernia.
Excellent answer. So sometimes the bladder itself can be the wall of the inguinal hernia. So when you're trying to dissect or cut or separate the sac, there's a chance you can damage the bladder. So it's always better to catheterize such patients. So you're going to decompress the bladder and it makes your job a little bit more easier. What about in recurrent hernias? Why do you need to catheterize patients in recurrent hernias?
They could be, sir, one is because it can take a little longer time to dissect because of the adhesions.
Answer is adhesions.
Yes.
So adhesions do not listen to you. They will happen in a haphazard manner. So the adhesion can be so dense that they pull up the bladder to that particular area. Okay. So you might assume, like let us say it can come to the area where your direct inguinal hernia comes because of the adhesion that the mesh has already caused. So when you're assuming you're in the right plane, but there's a chance you can cut through the bladder. So remember, in recurrent hernias, the bladder can get pulled up to your site of dissection. So make sure you catheterize such patients before you start. Next is regarding the positioning. The preferred position is a Trendelenburg's procedure with both the arms tucked. And the reason why we want head down is because we are operating in the pelvis. We do not want the small bowel to interfere with our field of vision. So you're going to put your ports, then get it head down so that all the contents come towards the upper abdomen and the lower abdomen or the pelvis is free for surgery. Coming to the ports. Now you're going to have a primary port and you're going to have a secondary port. Nitya, can you tell me where you're going to put your primary port and what is the size?
Sir, first umbilicus will be the primary port, and on either side of the umbilicus, in the paraumbilical region, exactly on the same line or little lower, we put two working ports, sir.
Okay.
That is for tap.
Yes. We're
Tap
talking
can
about
also
tap.
be.
We'll come there. We'll come to tap. So I do take your answer. I accept it, except for the fact that I would prefer to put the primary port above the umbilicus or in the supraumbilical port, supraumbilical region. The reason being, sometimes the mesh that you put might come very close to the umbilical port, which will hamper your working. If you're too close, you can't operate. Now, the latest hernia surge guidelines also suggest that the primary port should be supraumbilical, and
especially if the patients, some of the patients will have a very short segment of infraumbilical region and a very large, long supraumbilical portion. So in such patients, definitely you have to do supraumbilical port.
yes, sir. And like you said, the two 5 mm ports you will be putting on either side in the flanks at the level of the umbilicus. Now, this is usually 2 centimeters above and no, sorry, that is a mesh, my bad. So you're going to put it at the level of the umbilicus in the flanks. Okay. Idea is when you put these ports, you should be able to approach both the hernias, the right and the left. Now, in short, whatever I told you was for bilateral hernias. Whereas for unilateral hernias, you can do a little bit of change where, let us say we are operating on the, we're operating on the left side. Your port can come closer to the midline. One port can come closer to the midline. Can you tell me why? Let's ask Praveen.
For dissecting.
Nothing to do with the distance. Have you operated tap hernia? Have you assisted or have you done a little bit of tap hernia repair?
Yes, sir.
And how painful was it when you were trying to put the mesh and all? As a beginner?
Yes, sir. Yes, sir.
That's because your shoulders are abducted because the ports are very far apart.
Yes, sir.
Now, the reason we put it far apart is so that we can get access to both the sides. But if I'm only operating on one side, I don't need my ports to be so far apart. The ports can be slightly closer. All right. So my arms don't have to be abducted so much. I can operate them at a much more comfortable level. But please note, I repeat, this is only for unilateral. Now, if I try to use the same port for bilateral, can you see that it comes exactly in the way of my camera?
Yes, sir.
Okay. So make
Okay.
sure your port does not come in the field of your vision. So if it's bilateral, you're going to put it in the flanks. If it is unilateral, on the side opposite to the hernia, it can be closer to the umbilicus so that your arms are not abducted and it's ergonomically slightly better for you. Now we're going to raise the flaps. Now the incision is from the the medial umbilical ligament. That is the obliterated umbilical artery. And you're going to cut all the way to 2 centimeters above the level of the ASIS. And then you're going to define what we call as a myopectineal orifice. Now, can someone tell me what are the 3 hernias that you are going to define when you define the myopectineal orifice?
Direct, indirect, and femoral.
Femoral.
Okay. Rather than direct, indirect, it is inguinal.
Femoral and obturator.
Obturator.
It is the obturator hernia. Okay. So I told you this is the direct area. This is the indirect hernial defect. Can someone tell me where is the femoral? I'll give you option A, B, and C. Which is femoral in this? A, B, or C?
C.
C.
C. Because it's the external iliac which goes on to become the femoral, correct? So anything adjacent to this is where you're going to get your femoral hernia. Okay? And this is the pubic rami. This is the pubic rami. So what comes below this is what is called as the obturator hernia. So remember, whenever you're doing a tap or tap repair, you need to define this myopectineal orifice of Ricard, where the 3 hernias or the 3 defects that you're supposed to visualize are your inguinal, the femoral, and the obturator. And your mesh is supposed to cover all these 3 areas. Now, what is the mesh we are going to use? Is it heavyweight mesh or lightweight mesh? Praveen.
Weights.
What? Lightweight.
Yes.
And what is the definition of lightweight mesh? Less than 50 gram per meter square. Okay. Heavyweight is something more than, I think, 70 or 75 gram per meter square. That is what we call as heavyweight mesh. So you are saying lightweight mesh is the answer. Yes or no?
Yes, sir. Heavyweight issues.
Pardon me?
Heavyweight.
You want to use heavyweight mesh. What are the okay, I don't want to get into it. See, heavyweight and lightweight, all these are old concepts. As in we still use it now. But earlier they used to use heavyweight mesh because they thought the heavier the mesh, the more protection it is going to give. But instead it hampered the mobility of the patient because of the bulkiness of the mesh. And later on, they realized it is not the density of the mesh that gives the strength. It is the aseptic fibrosis or the aseptic inflammation that happens, which is what generates the strength. So then they started preferring to use the lightweight mesh because that was more elastic. At the same time, it gave the amount of strength that it had to, and it was a lot more comfortable for the patients. So ideally, what we use is the lightweight mesh, except for a few riders, and I will get into it after I discuss the next point. Now, there are various ways of fixing the mesh. You can either use glue, tackers, or you can leave it without any fixation. What are the types of tackers you guys know?
Observable and non-observable, sir.
What are the advantages and disadvantages of each?
Non-absorbable will have chronic pains.
Non-absorbable will have what?
Pain, sir. It is chronic pain.
No. in reality, they have found that they have no difference in terms of morbidity. Absorbable, non-absorbable are the same. Now, for those of you assume if you put absorbable tacker, if the nerve gets entrapped and it will get dissolved and go away and the nerve will become all right, it doesn't work like that. Non-absorbable tacker, but these are all very, very rare. But if you look at pain, if you look at the risk of complication, bleeding, the rate of recurrence, it is the same in both absorbable and non-absorbable. I'm sorry, just give me 1 second. Yeah, am I audible?
Yes, sir.
Yes, sir.
Okay. Sorry, I think there was some issue with my network. Now, the alternate option to using tackers is to use what we call as a tissue glue. The only downside is that it is very expensive. Do you guys know how much it costs? This is the tissue glue applicator. They apply glue and they get the mesh to sit in place. As far as my knowledge goes, anywhere between 10 to 15,000. Okay, for one particular application. So it's a very, very expensive thing. The last one is no fixation. That means you put a big enough mesh which corresponds to your site of dissection and it is going to sit in place without any issues. That is no fixation. So whenever you're doing this no fixation technique, they have found that using a heavyweight mesh is better in terms of recurrence. Otherwise, lightweight mesh is good enough for everything, especially if you're going to use glue and tackers. But if you're not fixing the mesh, then the preferred way to go is to use a heavyweight mesh. Finally, complications. Can you tell me what are the most common complications you guys know of? Praveen,
Immediate complications would be
go ahead.
immediate complications would be hemorrhage, sir,
Okay.
bleeding,
Seroma,
and
inguinal
dynia,
recurrence.
recurrence.
Okay. So there's still a huge list. But what you guys have to remember with regards to anatomy, if you want to avoid bleeding, don't do anything in triangle of doom. Seroma, not in your hands, that depends upon the size of the sac. Inguinal, don't put tackers where? In the triangle of pain. Recurrence, like we told, if you're going to use fixating devices, then use a lightweight mesh. If you're going to use, no, if you're planning to not fix the mesh, then better to use a heavyweight mesh. Now moving on to TEP. Now there are certain relative contraindications and absolute contraindications. Like I said, GA is an absolute contraindication. That means the patient is, unfit for GA, not only GA, unfit for GA. Relative contraindications, anticoagulants. Now here, this is where this comes into picture. If you have done previous surgeries in that area, getting into this preperitoneal plane is not easy. Because of the scarring, this plane might get disturbed. And first of all, the vision is not that great. Like I told you, it's like hiding behind the curtain from one end, going and trying to get out. There is not much vision there. You're working in a very narrow space or a narrow area. So previous laparotomies, previous surgeries, presence of ascites, strangulated hernias, giant hernias, all these are a bit difficult to tackle when you're doing TEP repair because you don't have much space. Now, the reason why I put strangulated hernia here and not in TAPP is the latest guidelines do say that strangulated hernia can be managed using the TAP procedure, but not TEP. They can be managed using TAP, but not the TEP. For exam, guys directly are going to write it as open hernia repair. Do not even talk about TAP and TEP. This is for knowledge that you can attempt a tap repair even in strangulated hernias and even put a mesh if there is no gross contamination. Now, in tap repair, where are the ports placed? Nitya.
Sir, one is in the around the umbilicus. First, we create the plane. That is, we incise the anterior rectus and then we dissect the muscle and we go. And then the other two, sir.
Wait. Where is the incision made first? You please talk, like a surgeon. Where do you make the incision for a tap first?
Sir, along the inferior part of the umbilicus, slightly over the lateral aspect. In the umbilical region, slightly over the lateral aspect.
Why
Sir.
Slightly lateral?
Sir, for easier maneuvering of the...
No. See, in the midline, there is linea alba, right? And the peritoneum is usually densely adherent there. Now, the idea is to get into the plane between the peritoneum and the muscle on top. If you try to go in the midline, there's a chance you'll enter inside the abdomen because that plane is not very well defined in the midline.
Okay.
So that is why you go slightly lateral. That's the reason they've taught you that word. There is a reason behind why they've told you that you have to go slightly lateral.
Okay.
Okay. So the first one will be in the umbilicus or the infraumbilical region where you're going to develop the space of Ritzius or Bogros.
Ritzius, sir.
Ritzius, excellent. And the lateral space is called as?
Space of Bogros.
Excellent. So you're going to create this place of the space of Ritzius. Then two more ports you're going to use. One is just below the primary port. The other one is just above the pubic symphysis, 1 or 2 centimeters above the pubic symphysis. Now, the advantage with TEP is whether it is unilateral or bilateral, the ports remain the same. You can, with the same ports, you can go medial and you can go lateral and finish your hernia repair. Like it is not very, because here you don't have abduction. But can you tell me what is the stark difference between TAP and TEP with regards to the way the ports are placed? Nitya.
Camera, sir.
Tanya.
After creating the space, only then we put the...
No, forget about all that. With regards to the port placement.
Triangulation, sir.
Triangulation is lost.
Correct. So what is this orientation called as?
Linear.
Sectorization.
Okay.
So you see that everything is in one sector, okay? Like, so the camera is seeing there's no triangulation. There's no triangulation. Camera is supposed to be in the center and ports are supposed to be on either side. So this is how gynecologists do hysterectomy. If you have seen, they stand on one side and operate. But if you see certain general surgeons doing hysterectomy or assisting, we tend to stand near the head end and do it where we are more comfortable with the triangulation. All right. So like we've already discussed, first thing is you're going to define the pubic symphysis, push the bladder down, and this is called as the space of Ritzius. Then you're going to identify the inferior epigastric vessels and then carry the dissection laterally. And that is the space of Bogros, laterally. Otherwise, the dissection more or less remains the same whenever you're dealing with a TAP or TEP. The same myopectineal orifice of Foucault is supposed to be defined. With regards to mesh, tackers, complications, more or less the concepts, whatever we learned in TAP remains the same in TEP procedure. Now, quickly, someone tell me what are the advantages of TAP and what are the advantages of TEP and which of the two is better? We'll ask Sanya best. I think she'll be able to cover maximum number of points.
Sir, for starting with TAP, access is easier compared to TEP.
For some reason, first of all, please keep saying TAPP and TEP rather than TAP and TEP. Because internationally, it is not accepted to call them like that. They, most speakers say TAPP and TEP.
Yes, sir. Noted. I think it makes sense.
To avoid the, because this sounds similar, that's why. Okay, Sanya, carry on.
Yes, sir. So, so with the TAPP, the access is easier to enter into the peritoneal cavity. When compared to TEP, it is for the initial beginners, it is slightly difficult to identify the retrorectus plane and
So
proceed inside.
basically, learning curve is more.
More,
Next.
yes, sir. And um,
That's all. What about
Yeah.
bowel injury, vascular injury,
Yes,
rate
yes,
of
sir.
recurrence,
Yes, sir.
complications?
Yes. Bowel injury is more with TAPP when compared to TEP, sir. And vascular injury, on the other hand, is more with TEP when compared to TAPP. And recurrence, I'm not sure if there's a difference between the two, sir, with recurrence.
So which of the two is better according to you?
So for initially for learning purpose, I think TAPP is better. But
So according to you, when you're learning, it's okay to experiment on the patients. Once you're professional, you
no,
go
sir,
into
no.
TAP and do very good.
No, not like that, sir. But because of the learning curve, I feel TAPP is better.
Okay. So few things that you need to know in TEP. It's a very limited field. Like I said, you don't have much space. The port setup is different because it is sectorization and not triangulation. The ability to tolerate pneumoperitoneum is very less with TEP because peritoneum is a very flabby structure, right? So if air goes inside the peritoneum starts getting pushed up, so your area becomes more and more narrow. So your ability to tolerate pneumoperitoneum becomes a lot more difficult when you're using a TEP procedure. So how do you counter this, Sanya? If you encounter pneumoperitoneum when you're doing TEP?
We can put a Veress needle, sir. So into
Excellent.
the peritoneal cavity.
Excellent. So that will allow the pneumoperitoneum to keep going out. Second is poor ergonomics when it comes to TEP as compared to TAPP because the space is much closer. The ports are much closer to each other. Now, with regards to the actual morbidity associated with the procedure, in terms of hematoma, recurrence, vascular injuries, mesh infection, both are same. Now, what you thought vascular injuries are more common in TEP? No, it is the same risk whether you're doing TAPP or whether you're doing TEP. Okay. However, you were right on one point when you said visceral injuries and the risk of port site hernias are more with TAPP. Okay, they're much higher with TAPP as compared to TEP. And risk of conversion is higher with TEP. Okay, so these are the major differences between TAPP and TEP. Otherwise, I told you more or less both are the same in terms of recurrence, in terms of outcome for the patient. So at the end of the day, it depends on what you are comfortable with when you are dealing with such cases. Now,
sir, one doubt there.
Yes.
If we have like pneumoperitoneum that is not settling with Veress, is it indicated that a TEP should be converted to TAP, or there any indications where TEP should be converted to TAPP?
There are no indications. It depends upon your comfort. And I will get to that point next.
Okay,
there is a modification to TEP that is being done to counter these things.
Okay, sir.
If you have difficulty and you're more comfortable doing TAP, please convert it to a TAPP and go ahead and finish the procedure. There's no harm in it.
Okay.
Okay. Now, you actually hit the nail on the head because I was about to say in TEP, like we discussed, we're operating in a very narrow area. And to counter this, they have come up with the concept of ETEP or ETEP. Can you tell me what that is? Extended or enhanced?
Extended.
Correct. Extended or enhanced TEP. That means a slightly bigger version of the same procedure, or where you're going to create more space as against to where you're limited to below the umbilicus. Now, quickly before we understand the ETEP procedure, you need to know that there is something called rectus abdominis muscle. Now, it is covered by the aponeurosis of the three lateral muscles. That is the external oblique, the internal oblique, and the transversus abdominis. So they give laminas and they're going to form a sheath in the front and a sheath in the back of the rectus muscle. So that is called as the anterior and the posterior rectus sheath. Now, one particular important anatomical, one important anatomical information that you need to know is that there is something called as the arcuate line. Now, at or above the level of arcuate line, that is midway between the umbilicus and the pubic symphysis, is where you're going to get the arcuate line. So somewhere in this area, assuming this is the umbilicus, this is the pubic symphysis, this is the arcuate line. So above the level of arcuate line,
2.5 centimeters below the umbilicus is where it is described, but the arcuate line.
yes, sir. So like sir said, apart from the landmark I told, even 2.5 centimeters below the umbilicus is also where the arcuate line lies. So above the arcuate line, you will have both anterior and posterior rectus sheath. Below the arcuate line, you will only have anterior rectus sheath. Posteriorly, it is deficient. Okay, all the three aponeurosis run anteriorly and nothing runs posteriorly. This is something that you need to be aware of. All right.
So Nikita, what do you call that hernia that happens at that level then?
Very easy. Some superhero, if you remember.
I didn't get you, sir.
Below the arcuate line or in and around the arcuate line where the posterior rectus sheath is deficient, there is a hernia that occurs and it's a named hernia. What is it?
Pygalium.
Pygalium.
Yes. Okay. So now just few words about the ETEP procedure or the extended totally extraperitoneal procedure. So see, like we discussed, let us say, okay, this is the head end, this is the foot end. You can see this is the hernia. Assuming this is the umbilicus, all our ports were here and we were working in a very narrow area. Now with ETEP, what they said, let us open up this entire area. So that gives us more access, more space to work. So even if there is pneumoperitoneum, we can counter it because we have more space to work. All right. So for that, they came up with this ETEP procedure where they start above the level of the umbilicus and then work your way downwards towards the inguinal region. Now here also there are two ways of doing it. There is something called as the same side or the opposite side camera port placement. What they mean is that your port, the primary port which is above the level of the umbilicus, can either be on the opposite side of the hernia or it can even be on the same side of the hernia. Because you're quite far away, you can put it whichever side you're comfortable with. There is no strict rule that it has to be on the opposite side. It can be on either side of the umbilicus. Okay. And then the other ports will be like how we're going to do a TAP procedure or a TAPP procedure, where you can do it with triangulation. So with the same plane, with the help of an extended view and with the help of triangulation, they countered all the limitations of TEP. Okay. Otherwise, rest of it remains the same. The mesh, the tackers, the complications of ETEP remains the same as TEP, except that here the mesh you're going to use will have to be slightly larger because you're using a bigger area, and preferably fix the mesh. Why? Because you've created a large area. So if you leave it unfixed, the mesh can migrate up and down and you can have the risk of recurrence whenever you're doing a ETEP procedure. So quickly, the advantages of ETEP versus TEP, it is faster and there is easier creation of space because you have a larger area to work with, large field, flexible port setup. Like I told you, you can either be on the same side or the opposite side with the help of triangulation. Even if there is pneumoperitoneum, you have a larger space to work around with. So there is better ability to tolerate pneumoperitoneum when you're doing the ETEP. Better ergonomics, like I said, triangulation. So that is the reason nowadays people prefer the ETEP as against the TEP procedure, because it uses all the advantages of the TAPP, but you're still in the plane of the TEP procedure.
Sir, I have a doubt.
Yes.
In the same ETEP, can we tackle the umbilical hernia, sir?
Yeah.
You will have to go much higher. You'll have to come, because see, for every hernia that you're going to approach or you're going to do, you need to put a mesh at least with 5 centimeters overlap, correct? 5 centimeters
Yes,
on
sir.
top, 5 centimeters down. So in such a scenario, you're going to start from higher up.
Okay.
Higher up, define the umbilical hernia and then go lower down, finish the inguinal hernia and put a mesh in the inguinal region, fix it. Then again put another mesh near the umbilical region, close and come out. That can be done.
Okay.
Only thing is
Okay.
here in the umbilical, you will have to cross the midline, you have to create this one. So that is much more complicated.
Yeah, it's a
Oh,
bit more of a, I can't call it a mess. It's a bit more difficult when compared to IPOM.
okay.
Okay. Now, sir, just 5 more minutes, sir. I just think I have 1 or 2 slides, if I may.
Yeah, I think. Yeah, no problem.
Yes, sir. So when it comes to recurrent hernias, first thing is when you're doing it laparoscopically, I told you in the exam, the answer is to say if it's laparoscopy, you're going to choose open. If it's open, you're going to choose laparoscopy. However, if you are doing laparoscopy and you are doing a ETEP repair or a TEP repair for a recurrent hernia, remember the plane of the hernia should be between the abdominal wall and the mesh. Okay, don't try to go between the mesh and peritoneum. So pull the mesh and peritoneum together, push the abdominal wall and try to go in between these two. Do not try to separate the peritoneum from the mesh because most of the times that is where the holes in the peritoneum will happen and that will make your life a lot more difficult. So better to go between the mesh and the abdominal wall. First step is identify the inferior epigastric vessels because this is where bleeding most commonly happens from. And how are you going to...
Where do you want the inferior epigastric vessels to be when you're doing the dissection?
On the roof or on the floor? That is what sir is asking.
On the roof, sir.
Yeah. Always keep it on the roof. If sometimes it will hang down. What will you do when it hangs down?
So then be more careful about it.
No. You have to fix it. Fix it to the roof.
Can we fix it, sir? Won't it cause bleeding if we...
No, it won't. The thing is, when it hangs down after you've dissected, it will keep coming in the way, and for you to place the mesh and things will be difficult. So
Yes,
you will
sir.
have to fix it to the roof.
So fix it how? With a suture or with a stitch? Okay.
Yeah.
You can even use what we call as a U-stitch. Put one thread on this
Yes,
side,
sir.
bring
Pull
it
it up.
out to the opposite.
And after that, you can take it out. Yeah.
Okay.
Sorry,
Now,
Nishant. I think, but it was important for the.
yes,
that's
sir.
why I asked only
My next point was
standard.
actually that, sir. Okay, bleeding happens from the inferior epigastric vessels. If it bleeds and you're doing a case of recurrent hernia, or if you're worried about bleeding, they even suggest tying off or ligating the inferior epigastric vessels early itself. They don't even want you to get into the junket of entering the bleeding. In recurrent hernias, this is not general, I'm telling you. In recurrent hernias, if you're worried about bleeding, worried about adhesions where you can't define the inferior epigastric artery well, they've even suggested ligating the inferior epigastric vessels. One point regarding adhesions. What has been mentioned in the guidelines is if there are adhesions, there is unlikely to be hernia in that area where there is dense adhesion. Hernia has happened because there is no adhesion. Okay. So if you are working in an area with dense adhesions, that is not the site of the hernia. That means you need to reassess and look because first of all, the planes will not be correct. So that is the idea. And preferably use a larger mesh whenever you're dealing with recurrent hernias. So few controversies that have been addressed in the latest guidelines. Indications, we have already covered it. Okay, I've told you earlier it was for only bilateral and recurrent hernias. Now they're saying everybody can undergo a laparoscopic hernia. That is mentioned in the latest guidelines. TAPP versus TEP, I've covered it. Everything is the same. But if you want to talk specifically about complications, bowel injuries are higher in terms of TAPP as compared to TEP. Otherwise, vascular injuries, everything are the same in both the procedures. Mesh type, like I told you, what we have addressed is whether you need to use heavyweight or lightweight. If you are going to use fixation, that is like tackers or glue, a lightweight mesh will do. But if you're in the habit of not using any fixation, then they recommend to use a heavyweight mesh. Fixation, we have covered either glue, tackers, or no fixation. Glue is very expensive. Tackers with regards to absorbable, non-absorbable have the same outcome even with regards to pain, okay, and regards to adhesion formation. But because it is a non-absorbable tacker, sometimes it can cause more amount of inflammation. They can cause intestinal obstruction and they can cause erosion into the bowel if the tacker is sticking out into the peritoneal cavity.
So
And with
any
regards, yes, go
sorry,
ahead.
sir. Any difference with outcome with glue and tackers, sir? Even though glue is
No,
expensive.
no,
difference.
because
Okay.
they have found the outcome is the same even if you don't fix the mesh.
Okay, sir. Okay.
The
Yes.
usage of glue and tackers is if you are going to use lightweight mesh and it is more for your comfort rather than it actually giving a very great outcome.
Yes, sir.
Okay, well in glue
Yes.
definitely the pain is lesser when compared to tackers, but between absorbable and non-absorbable there is no difference with regards to pain.
Okay, sir. Yes.
So these were the controversies with regards to laparoscopic inguinal hernia repair. Hernia is a very, very, very large and vast topic which can't be covered in one class. Even though I tried to restrict myself only to TAPP and TEP, we still overshot by about 15 minutes. And that's it. Any doubts or questions from the postgraduate students first? And of course, Sanya and Nitya as well.
Sir, in normal TP, apart from the midline secondary ports, can we still put a lateral port, sir? Because here,
you don't
Muni
need
Reddy
to.
sir and all.
No, listen, you don't need to, but you can always add more number of ports if you're comfortable with it.
Okay, sir.
Whatever I've said is what is the recommended one and what is the most universally followed. But that doesn't mean that has to be the exact port placement. As long as you have the basics of laparoscopy and ergonomics in place and you're following the principles of dissection and putting a mesh, you can do whatever you want.
Comments from postgraduates and registrars. Next, Ramakrishna sir, if he is there.
Hello, sir.
Please, sir.
What she was talking about lateral ports in TEP. Actually, Dr. Palnivelu, he does it. He puts a camera and all dissection is done through camera. And when he goes laterally and sufficient space is there, he will put a lateral port just like you use in TAPP on either side. With that, he continues. It's not ETEP. In TEP only, he does it.
Instead of midline, instead of sectoral ports, he'll put lateral also.
Lateral. Just port placement, ultimately, if you see from exterior, it looks like TAPP ports only.
Okay.
With camera only, with the telescope only, he does these lateral dissection and all, and gets enough space so that he can put a lateral
Sir,
port.
but is that for bilateral hernia or unilateral, sir?
I don't think it makes any difference. In both, he does.
So why
And
dissection
the other one, the other point I just wanted to, regarding fixation, suture fixation also can be done. So we can take a needle inside and fix it to this Cooper's ligament, and sometimes another stitch onto the rectus. He does only one fixation. That's what he recommends, but it may not be in the guidelines. Just wanted to tell you. And the GA, unfit for GA, is an absolute contraindication. I think it should be relative. In fit patients with good respiratory reserve and all, even literature is also coming up. They do it under spinal anesthesia. It's not condemned. Only these 3 points I just wanted to add, sir.
Thank you, sir.
But the main problem, Ramakrishna, is that patients are extremely uncomfortable because there is severe shoulder tip pain. And so I think patients who even with spinal, the shoulder tip pain is not addressed, and they will be very uncomfortable and they will be wriggling around. So I think that is a problem.
No, sir, they manage with sedation. It's not very difficult, I think. It's not, we, even appendicectomy and all we do under spinal, no? It should be the same thing here also. In appendicectomy also, we take head low position, perhaps with right lateral, sorry, left lateral. But we don't find this shoulder tip pain so often. Sometimes we get, yes, but not in every case. They manage with little sedation and all.
If there are no comments from postgraduates, I think it was, excellent class by Nishant. He did a very good job. I think,
Yes.
displayed the anatomy very well, explained the concept of the triangle of pain and the triangle of doom very well. I think I had not heard that by anybody else. I think it was very good. So you could all understand why it is so and how, the reason for that. So, I think all in all, excellent class for both, and just people who have just started and for people who have been doing it also. Thank you, Nishant.
Thank you so much, sir. Thank you so much.
So we'll close the class. Good night.
Yes, sir. Thank you so much, sir.
Thank you.
Good night. Good night.
Thank you, sir.